Very fast, very quickly. Great evening, great talks. I'm going to try and sum up in a little bit of time. I was given 5 minutes. I had asked for 2 minutes extra. To start with, I'm going to start making something. Can I have the next slide, please? Next slide, please. Just, because the entire session was initially of the ERPR positive, just to tell you that unfortunately, ERPR positive patients will continue to relapse. The relapses are late and there are various mechanisms. I'm not getting into those details, but just try and tell you that it can be gain of functions, it could be activation of other pathways, they can be ligand independent, they may be ER location and type and splice variants, it can be antagonists and agonists, and there may be mutations that regulate ER expression in aberrant methylations and exons. Any relevance to this? The relevance has been both in Dr. Jyoti's talk and Dr. Shahu's entire issue of doing the panel discussion. Next slide, please. Well, that's just covering it up, and I think that tells you everything of the pathways that we are dealing with breast cancer on today's date. One, we have the growth factor pathway, and you can see that in the HER2, and the other part is with the EGFR. We have the other pathway, which is basically looking at the hormonal pathway, the blockers, which they are, and also we see a place where they come and meet the common pathway. I want you to focus on this common pathways because the cyclin D1 place and the cyclin D CDK4/6 inhibitors have a role to play, which is actually going to become more important as time goes by. Next slide, please. So are we choosing it right? I'm not going to get into this, but just tell you all that this is the commonest mutation. 40% is what we see. Next slide. Okay, and what we know is that we're going to see much more activity in this space because at the end, the CDK4/6 pathway is going to actually get the mTOR pathway, and we are going to have basically the metabolic pathway being a much more important where we will be seeing things. JAK-STAT pathway is the other pathway, but that's outside the purview of today. Next slide, please. Next slide. The PI3 kinase pathway, which we know the apicillin has come in, is a promising pathway and results in AKT inhibition, also in TNBC. Please remember, it's just not for hormonal, it's also for TNBC. But the question is, what is the best target pathway and what is the sequence to this? To better understanding, we're going to see more. We need biomarkers to actually answer this. Next slide. So the take-home message is, we have a favorable prognostic with the PIK3 kinase mutations in early breast cancer, but in late breast cancer, later lines of breast cancer, actually this causes a lot of poor prognosis. It doesn't have too much of predictive value. For aplicable, the tablets, we have the target PI3 mutase that has been identified, a specific method of doing it now available in India. We can use tumor tissue, or even we can do it with the lipid biopsy. We can do a transgenomic solution. We need to actually now do, as a time came up and Jyoti said, that any patient who comes up front and shows us, we should start thinking of doing this sequencing to get hold of the PI3 kinase mutations early on. Next slide, please. Next. Okay. And please remember that PI3 kinase has got its own side effects. We have to take care of them. Jyoti brought it out pretty well. And it's worthwhile to keep working on this pathway. Do remember something, that the PI3 kinase pathway combined with fulvestrant has shown an important thing. But now a caveat warning. Next slide, please. And then that warning was basically, some of this missing in the slide is that we have a black box warning coming in for thromboembolism in case of PI3 kinase inhibitors. Dr. Shahu has done, as usual, a great job. And based on that, what we can tell you, that we can see that the endocrine therapy with CDK4 kinase inhibitors in advanced breast cancer should be the first line. Fulvestrant endocrine therapy with CDK4 when we have already been exposed to AI. Everolimus has evidence in multiple endocrine pathways. And if you have an ESR1 mutation, this was a statement that was made, that if you find an ESR1 mutation or you use a PIK3 kinase mutation, possibly using one of the ciclips won't be right. Aplaciclib has only data with fulvestrant in a later line, not relevant to this part. And this mutation sequence is important. Next slide, please. So this was a question, AI alone or AI combination, or is it with a ciclip? The question is, if it's endocrine name, if it is low volume, if it is non-visceral, it's low grade and less aggressive biology, it's worthwhile using an AI alone or a combination of AIs. But if it's a recently post-AI, if there's visceral disease, it's high-grade tumors. Next slide. And in spite of the relative hazards being same, whether you do it in the first line or you do it in the second line, or you do it in a low volume or high volume, do remember something, that the upfront use of CDK4 is actually got a higher absolute benefit, although the hazard ratios are same. Next slide, please. So just to put it in perspective, Shago has already covered this. If it's more than 12 months, you can use an AI, come with a CDK4/6 with a generous analog if you are a premenopausal. Consider AI alone if there's a lot of comorbidity or there's a hepatic problem where you might have to think of other methods. If it is AI resistant, start with fulvestrant and CDK4 straight away GnRH. If you have organ failure or you have basically a crisis, then start with chemotherapy and then switch over to endocrine therapy with CDK4/6. Next slide, please. This came up with the quick question that there's resistance in this pathway is also going to be there. You may have de novo resistance, like what resistance. I'm not getting into that. Next slide, please. Okay. Now, this is what I wanted to tell everyone. We were talking of, can we use AI combination front? If you do a network comparison across these trials, which is actually not there, I didn't go to see one, but if you do a network statistical transfer, which is mathematically using AI, and we do an analysis of CD4/6 before, or a PI3K for I before mTOR, one would see that if you use CD4K6 before, then you have a survival benefit in all stages of things. So the debate, which we can never be solved with a randomized clinical trial, which will never take place, is possibly going to be CDK4/6 before, followed by anything else. Please remember something, that if you were using any of the other drugs before and then CDK4/6, according to the network analysis, your outcomes are always poor. Slide, please. Okay, next slide. Now, this was the HER2 spectra, has been covered very well. We saw the new drugs we talked about. Next slide, please. Next slide. Well, that's the whole group, and I'll keep it here and talk about what Dr. Ved presented. First and foremost, he said that if you are a patient who's got a high volume disease, but is unstroke, and if there is a question of metastasis, the combination of two HER2s, starting with pertuzumab and trastuzumab, with the skeleton chemotherapy may be the right way. And the right way to that would be using the right skeleton. The right skeleton on today's date, all the data that we are actually seeing is docetaxel per se right now. And if I look at the whole spectrum, which is right in front of you, and I'll also come back and talk about when it was question is if a patient actually recurs after 12 months or progresses after 12 months of treatment, after a good response, let's get a biopsy done, because there is about 12-15% chances the HER2 may be not there, or the ERPR may not be there. In fact, both of them may not be there, and it might be a triple negative. We don't want to miss out on that. We know that the problem with HER2 patients are they didn't have a lot of brain metastasis. And when you have this brain metastasis, there's something that I want to tell everyone is that, remember, the larger molecules do penetrate the brain once you have radiated the brain, or if you have a breach in blood-brain barrier with already the tumor existing in the brain. So under those circumstances, ideally speaking, like in India, we would say a combination of capecitabine and lapatinib may be a good alternative once you're that across. But that's not a good choice. That's a poor choice. The better choice is to use a single drug if you want to use tucatinib. Or tucatinib can be combined with previous or even given with capecitabine. Next to it is maybe a choice of niraparib. Yes, we'll have to learn to live with the side effects that we have. Next slide, please. Well, that's how it is, and I'm not going to get into it because I had a feeling that Ashok might talk about early one. He did not do that. Next slide. So actually, I wanted to get into something is that maybe on today's date, in the COVID era, TDM1 may be a better choice than any other thing right now, where it is indicated because it's got less chances of actually creating a storm or creating an immune suppression. Next slide, please. So that's to summarize. We have to look into future strategies. We are talking about de-escalation. We don't have the issue of brain. I have a provocative statement to make to my colleagues out here that in a HER2 patient who goes on to systemic therapy, metastatic, and has a very good response, do we give a prophylactic brain radiation? Is there a 50% chance he or she's going to recur in the brain again? Do you think all we need to, once we do it, add-on might enter into the brain better without having a brain metastasis? Well, there's a conjuncture. We'll wait for it. But do remember that if you have a HER2 patient today, and if TDM1 is available, which may be a better thing data which you have for. Next slide. I'm going to close this up by saying, this is a picture of the anatomy hall. This is an area where actually we learn what we have to do best. So I will say thank you. Good night. It's been a great discussion. I really have enjoyed it.